Good morning, everyone. We're going to go ahead and get started. Welcome to our midwifery panel event. I'm Dr. Camila Barnes. I'm the Assistant Chair of the Undergraduate Nursing Program and also Associate Professor here at the Hofstra Northwell School of Nursing and Physician Assistant Studies. It is my pleasure to host and moderate this event and present our panel of midwives for this special event. First, I would like to thank the Hofstra Cultural Center for the grant and for support with coordinating this event. I also want to thank Dean McLeod for her support. Thank you also to Martine Hackett, the chair of the Department of Population Health, for providing collaboration during the planning phase. This month, we are also celebrating two occasions. We're celebrating Women's History Month, and we're also celebrating International Women's Day, which is on March 8th this week, and this is part of that programming. What a perfect time to also celebrate our midwives who have made significant contributions to the healthcare profession and to the communities at large. Thank you also to my nursing faculty colleagues who are here to support, and also our ideals team, Jessica and Dina, for supporting with coordinating behind the scenes. I would also like to acknowledge our undergraduate nursing students who are in the inaugural junior class and soon to be graduating. You're going to be nurses very soon. Currently taking maternity and psych clinical courses. We have 18 students who have expressed interest in pursuing a career path in maternal health, so that's amazing. And a few students will be moderating throughout this program. So at this time, I will discuss our program and also introduce our panelists. Also, when our Dean McLeod is able to stop by and give remarks, I will stop for brief remarks, okay? So we are gathered here today for a very important topic, addressing the maternal health crisis in the United States. Giving birth, the most natural experience in a lifetime, should be a time of joy. But for so many women and their families, this is not the case. Currently, over 1,200 women die each year during pregnancy and postpartum in the United States. The numbers continue to worsen, so we need action now. As an industrialized nation and medically advanced system, this should not be happening as the majority of deaths are preventable. All women deserve to go home to take care of their families and their babies. It is imperative that we continue to advocate for policy changes that affect all aspects of our lives, especially the need to address health equity and social determinants of health. In addition, we need to address the significant disparities with higher mortality rates amongst Black women. This is a global health issue, and it's also a human rights issue. Unfortunately, we have normalized deaths in this country as expected, and there is a lack of accountability when women experience unjust treatment, reproductive trauma, implicit bias, and systemic racism. As a healthcare profession, we need to do better and advocate on behalf of our patients in the communities in which we serve. We are very fortunate to have midwives with us today who have all contributed a lifetime of work in education, scholarship, research, community service, and capacity building. Midwifery is one of the oldest professions worldwide and is our maternity history. Prior to hospitalizations of birth, midwives were the birthing providers in our communities and also provided newborn care as well as doula support. A midwife is a trained and licensed provider who provides a full spectrum of services including pregnancy, childbirth, newborn care, postpartum health, and reproductive health, as well as many other services. Today, you will learn more about midwifery care and why midwives are essential to improving maternal and fetal health outcomes, reducing unnecessary medical procedures, and improving reproductive health. Currently, midwives attend 12% of births in the U.S., which has been increasing over the years. However, regulations with scope of practice and insurance reimbursement varies from state to state. It is imperative that we advocate against policies that hinder access to care to midwives, and also the development of community-based birthing models, such as midwifery-led birth centers and home births with low-risk patients, especially in areas where there are maternity care deserts. Diversity in the workforce is also critical and essential to provide culturally competent care and best outcomes in our diverse communities. I will now introduce our panelists. First, we have Nubia Earth Martin, if you can wave. So Nubia Earth Martin is a community birth worker and founding president of Birth from the Earth Incorporated, which is a nonprofit organization steeped in education and empowerment, providing a variety of health and wellness services for families and training for birth workers. In 2021, she opened Earth Grounds, a brick and mortar location in the heart of downtown Yonkers. Anybody from Yonkers? No? Okay. Dedicated to centering Black healing, Nubia holds a bachelor's degree in sociology, a master's degree in midwifery, and postgraduate degree in international midwifery and maternal infant health from Mercy in Action. Nubia has completed additional studies at Jenny Joseph's Common Sense Childbirth Midwifery School, who was also trained in the UK, and Birth from the Earth Grounds as a national perinatal safe spot. She sits on the advisory board for Chocolate Milk Cafe National, the Black Coalition of Safe Motherhood, and the Hudson Valley Birth Network, and is an active member of the Home Birth Midwives Collective in New York. Nubia is dedicated to improving birth outcomes for women of color and toppling maternal mortality and morbidity rates, disparities as well. The legacy and lineage of the Granny Midwives runs deep through Nubia Earth Martin. She sees midwifery not as a profession, but as a way of life and a rite of passage. Please give a round of applause for Nubia Earth Martin. And now we have Dr. Lucinda Canty, who is a certified nurse midwife, associate professor of nursing, and director of the SeedWorks Health Equity and Nursing Program at the University of Massachusetts Amherst. She's traveled far to come see you all. She earned a bachelor's degree in nursing from Columbia University, a master's degree from Yale University, and specialized in nurse midwifery, as well as a PhD from the University of Connecticut. Dr. Canty has provided reproductive health for over 29 years. Her research interests include the prevention of maternal mortality and severe maternal morbidity, reducing racial and ethnic health disparities in reproductive health, promoting diversity in nursing, and eliminating racism in nursing and midwifery. She is also an artist, poet, and historian, which she'll display a little bit later on. She uses her art and poetry to bring awareness in maternal health. She provides women's health care at Planned Parenthood of Southern New England. She currently hosts web discussions Overdue Reckoning of Racism in Nursing. She also founded Lucinda's House, a Black maternal health collective to promote maternal health equity through community collaboration and programs that provide support and education. Dr. Canty has received funding for her research for the Robert Wood Johnson Foundation. She has published in various journals, including AGN, American Journal of Nursing, Nursing Inquiry, Journal of Advanced Nursing, Birth, and Nursing Philosophy. Dr. Canty is a contributing editor for the Journal of Midwifery and Women's Health Ask the Midwife column. Additionally, she is a sought-after nurse scholar in addressing both maternal health equity and anti-racism initiatives. She is a frequent featured speaker virtually and in person at local, regional, national, and international conferences focused on the challenges of reducing disparities in maternal morbidity and mortality. She is a fellow in the American Academy of Nursing and the American College of Nurse Midwives. She is also the 2023 Yale School of Nursing Alumni Association Distinguished Alumni Award recipient and the recipient of the 2023 Florence S. Wald Award from the Connecticut Nurses Association. Please give a round of applause for Dr. Canty. And I'm reading their full bios because I want you all to hear everything that they've done. And then we have Dr. Michelle Mayer. Dr. Mayer began her professional career in 1973 with a Bachelor of Nursing degree from Adelphi University. With a passion for women's health as a career guide, she began working in labor and delivery room at Albany Medical Center for several years. A move back to Long Island found her in the delivery room at Long Island Jewish Medical Center. A Master's of Nursing and Perinatal Women's Health from SUNY Stony Brook followed, and Michelle changed directions, finding herself in the physician's private OBGYN practice as a nurse practitioner for almost 10 years. The desire to become a midwife was always there, and when SUNY Stony Brook launched their midwife program, Dr. Mayer was able to pursue a postmaster's certificate degree in midwifery and was able to remain in the private physician practice and begin attending births at St. Charles Hospital in Port Jefferson for almost 10 years. She furthered her career with a doctorate in nursing and midwifery in 2010. In 2013, Dr. Mayer was offered an opportunity to start a full-scope OBGYN midwifery practice, the first of its kind at Northwell. The challenge was accepted, and Northwell Midwifery at Huntington was born. The practice began in one small hospital office with one midwife, and during her 10-year tenure, it has grown to a robust and successful practice with 5 midwives, working in 3 community offices and attending births at Huntington Hospital. When Northwell Hofstra Graduate School of Nursing opened, she also had the opportunity to become an adjunct professor for the F&P program here. And retirement came in, not so retired, we still have her, came in 2022, but this did not end her career. Dr. Mayer continues working in a per diem role for her practice and as a guest lecturer at Hofstra University. Please give a round of applause for Dr. Mayer. Okay. And last but definitely not least, we have Dr. Patricia Burke. Dr. Burke is an associate professor at York College, City University of New York, and an adjunct at the Harriet Rothkopf Heilbronn School of Nursing at Long Island University, Brooklyn. Dr. Burke is originally from Ireland. She began her nursing career at Northwick Park Hospital School of Nursing in England. She also completed her midwifery training and worked at Perivale Maternity Hospital, now part of Ealing General Hospital. This is also in England. Dr. Burke earned a baccalaureate nursing degree from Pace University, we're the Pace folks, and a master's degree in perinatal nursing with a certificate as a perinatal nurse practitioner from Columbia University, New York. She also completed her doctoral degree at Capella University with a focus on cultural competency of associate degree nurse educators. Her area of teaching experience is maternal child health, and she maintains her certifications as an inpatient obstetric nurse. When she came to the United States, she worked as a staff nurse in labor and delivery at Maimonides Medical Center, then as a nursing care coordinator for obstetrics. She spearheaded innovative, and why is she getting all bashful over there? Talking about you. She spearheaded innovative programs that had a positive impact on client outcomes, implementing the 10 steps of the Baby-Friendly Initiative, developing the MAM, which is maternity at Maimonides, that's where I was born, Maimonides, program, a comprehensive educational program for prenatal clients in the clinics. The MAM was designed to reduce gaps in infant morbidity, mortality, and length of stay between the private and clinic populations. As the director of maternal child services at Holy Name Hospital, New Jersey, she worked with the medical team to provide midwifery services as well and developed collaborative agreement with the standalone birthing center. She planned and implemented a doula workshop for labor and delivery, mother-baby to improve client satisfaction and obstetrical outcomes. As an educator, Dr. Burke strives to increase student awareness of health disparities, examining factors that contribute to the unacceptable high rate of Black maternal morbidity and mortality. Please give a round of applause for Dr. Burke. So after this program, there will be a few minutes to network with our panelists, so please take advantage. I wanted you all to have the best of the best, the creme de la creme, and also you may have some future jobs here, so just FYI, okay? So now we're going to have a brief presentation by Dr. Canty, and then I'm going to ask our Dean McLeod to come up for remarks. So,
okay, thank you for that introduction. So I just want to talk just really briefly And because we don't have the ability to really show. Oh, is anything showing? I'm logged in. Is anything showing? Oh. No. She helped just to remember. I'm just be really quick. Yeah, so that's, it's not mirroring. I just need it to mirror.
Yeah, that's not mirroring. It's just showing her home screen.
I don't remember how to mirror. Let's see. Sorry, I'll be very brief. It's really just to talk about why, and just to give you some imagery before we get started. But just to show, okay, so here's the presentation. Just to kind of talk a little bit about why we need to have this discussion about midwifery. Okay, now oh, perfect, thank you. Okay, so just really, when we're thinking about maternal health and the maternal health crisis, we have to be aware of the racial disparities that exist. And oops, is that screen showing up with the sign in? Okay. Okay. And so, and just so you're aware. Oh, sure. How is this? Is that better? Okay. Yeah, so just with Black maternal health, it's just really important to recognize the disparities that exist. And when you look at maternal health, there's so many areas. There's, maternal mortality, severe maternal morbidity, those life-threatening conditions that, again, could be prevented. But also when you look at infertility, when you look at perinatal loss, and that's miscarriage, so that they lose that pregnancy before 20 weeks. Those G's and P's that you're learning. So before 20 weeks is considered miscarriage, after 20 weeks is considered stillbirth. And just know that among communities of color, there's disparities that exist. But in infant mortality, and there's two ways, again, with that loss is within 28 days, which is considered neonatal loss, and infant loss is within 1 year. But the problem is that we talk about social determinants of health, but we need to understand those root causes. Because you can have insurance, you can start prenatal care and go to every visit, and we're going to talk more about this, but to know that the disparities still exist. And race is not a risk factor, is really racism. And we're going to talk about different ways that shows up. But just to put this into historical context, this is from the movie Roots. How many of you have seen that movie? You probably weren't, okay. Those of us who were born during that time. No, I'm only kidding. But it's a good movie to watch to understand, again, our history. But also, I just want to say how midwifery was celebrated. So midwifery birth was celebrated, and midwives kept the women safe. There was a community that was there. But when there was a shift from home births to hospital births, Black women were left alone. Our communities were taken from us that offer that protection. And we'll talk more about the context of where we live. But I just want you to keep that in mind. And midwifery has such an essential role. Nursing as well, because as nurses, you're in the core of this. And that's whether you all know that pregnancy shows up everywhere. You could be in the ICU and have a patient give birth on you. So I'm just letting you all know who says, I'm not going to work with pregnancy, so I don't need to know that. Just keep in mind that pregnancy shows up everywhere. So in that way, I have this rule, pregnant until proven otherwise. So you come and see me, talk about you have an earache, you get a pregnancy test. So anyways, just keep that in mind as we go through. And really what we're saying is that we're thinking about, because this is an old issue, racial disparities, the maternal health crisis in the United States. So look at that history. You'll see since 1987, our numbers have soared. But our technologies allegedly and research has improved. So why is it that women are still dying at all in this country? And the numbers are alarming. Compare us to other countries and you will see where we stand. We should be doing better with the technology and knowledge that we have. So that's what it's really today is about, is talking about how midwifery can really contribute to improving those things. But we're going to talk about, again, how to show up for your patients in a way that regardless of where they're coming from, you're going to provide them with quality care.
Thank you, Dr. Canty. And now I'm going to ask our Dean McLeod, Dr. Renee McLeod-Sorgen, to come up to give brief remarks, and then we'll get started. We're going to lift up the screen, and then our panelists are going to come up.
Thank you, Dr. Barnes. Well, good morning, everybody. Isn't this exciting? Yeah. Just let me know by show of hands how many are really excited to have this esteemed panel because you're looking forward to being, and love it. So I too, like Dr. Barnes, was born in Brooklyn. I'm a proud delivery of Kings County Hospital, which is part of Health and Hospitals Corporation. And I didn't even know until about 5 years ago when I finally looked at this torn and tattered birth certificate. Yes, Dr. Canty. I'm one of those people who watch Roots as the original with antennas. That I was delivered by a midwife.
Wow.
And my mother at the time that she delivered me was 41. And I was the youngest of 5 and the only born here in New York, with my sister being born at home 17 years before me, and my brother being born at home 16 years before me. So that's probably why you're stuck with a dean that's so crazy, because you know they probably dropped me. And I used to tell a later attending who was chief resident at Downstate that year, Sam, is Dr. Sam Packer, why didn't you catch me? And he said, because the residents weren't allowed to cross the street. The residents only came into Kings County Hospital if there were a problem. So personally, I want to thank Dr. Michelle Mayer, and I really want to thank Michelle for all of the work that she did at Huntington. And she single-handedly lifted up the family nurse practitioner program for many years here at Hofstra. I also want to thank Dr. Burke and Dr. Canty and for all that you do. And I really want to thank the entire panel because you are highlighting what we know to be true, that if this were not 1966 when I was born, if this were the year 2024, when July 13, 2024 comes around, I might not be standing here 58 years later, because for Black and brown here in New York, preeclampsia, post-birth, gestational hypertension, HELP syndrome, everything that you are learning about kills a young woman of color almost every month, every day. So you are my future nurses. Listen really closely, because discernment is important. To look at that woman's face, that pregnant person's face, because not every gender will be female, and know that you are at the front line between them and death, between their child having greatness a half a century later. So that greatness is because of these 5 women on this stage. And I thank you for coming to Hofstra, and I thank you for every woman's life you save. Thank you so much.
Thank you so much, Dean McLeod. And we're going to get started with the panel questions. We're going to start with the student question. I had a lot of fun working with students, coming up with some panel questions, and we'll get started with Allegra. Anybody can answer.
Yeah, I don't mind to start. Greetings, I'm Nubia Earth Martin. So for me, I'm a mother of 5. So it was the experiences giving birth to my own children and seeing the difference in care that I got. My first 2 were born in hospital, and my last 3 were born at home with midwives. And it was really the difference in the type of care, right? So it was continuity of care. It was seeing the same provider throughout my pregnancy. It was having my needs centered and being an integral part of my own care. And I believe that can happen in any setting, but the provider has to understand that the most important person or people in the equation is the birthing family. So that type of care that I received, I was like, oh, I want to do this for other people. Everybody deserves to have, this type of care and experience. So that's what started me on my journey. I started as a childbirth educator. Then I became a birth companion, also known as a doula. Then I became a postpartum birth worker and a lactation consultant, and eventually realized that all of these things are part of midwifery care, right? There's so many facets to being a midwife, so many facets to nursing. There's the education piece, there's advocacy, there's the actual care, preconception, information, following somebody through a pregnancy, postpartum care and rituals. So for myself, it was very personal. And then seeing some of the lack in my immediate community. So I'm in Yonkers, which is right outside of the Bronx, where we have a really high rate of disparity. I wanted to make sure that those resources were available to the people who need them the most. So we offer a variety of free services, including childbirth education workshops, village baby showers, Fatherhood Fridays, lactation support, just to make sure that that's never going to be the barrier to why somebody didn't receive those things, like a financial, barrier. So that's my personal, journey. And I think as you guys are on your, pathway, there are going to be certain things that happen either in your life or in your interaction with community that's going to give you that kind of like whisper in your ear that this is why you're doing this. And making sure that every family that you're caring for, you realize that this is unique for them. This might be their first time or their fifth time, but every pregnancy experience is unique. So thinking about it that way, that really speaks to the individualized model of care of midwifery and also nursing. Yeah.
I guess I can go next. All right. Yes, thank you. I first have to say how humbled I am to be in the same room with all of these esteemed colleagues. I mean, this is just a joy for me. I just love this. And I know it was mentioned before that you can deliver anywhere where you don't know where are you going to be. And I just heard yesterday about an airplane that was traveling over, I think it was over Asia, and a woman must have gone into labor, and the pilot told the co-pilot, "You're going to drive the plane, and I'm going to deliver the baby." So you do truly never know when that's going to happen. And when we think about inspiration, it's such an interesting question because, as you could hear, I mean, I certainly graduated in '73. I'm sure you can do the math, but I never thought I would be at this stage of my career. I was always living in the present, and as a teenager, I loved to hear the birthing stories of my mother and their friends, and I was so fascinated by that. And then in college, I attended Adelphi, and my OB instructor was Dr. Jacqueline Hott, who anybody who is on Long Island knew of Jackie Hott, and she was wonderful, inspirational, and I knew with my passion for women's health, this is what I wanted to do. I had the opportunity to live in Europe for a few years in Bologna, and I was so fascinated by the midwives there that I actually applied to the school there, but fortunately or unfortunately, I found myself expecting my first child, so the plan had to be deferred 3 children later. And so certainly midwifery was always something I wanted to achieve, but unfortunately with 3 little children, it was hard for me to attend a school that was very far away. So when Stony Brook opened their school for midwifery, I was in the second cohort. I was thrilled. So I know where you have been. I've been where you are now. And at the time I thought labor and delivery room nurse, that's my future. That's what I'm going to be. Well, I didn't realize that the decades passed, and I still, didn't know what I was going to be when I was, later on in my 5th and 6th decade. So certainly, the world is your oyster. You can certainly find your passion, and you will love it. And so midwifery was available to me at Stony Brook University. I loved it. The position I had, I was fortunate enough to work with a physician who was very midwife-like, and I learned a great deal from him, and he built a lot of confidence in me, and he taught me so many things that you never know where you're going to get all your information from and how you're going to learn. So I commend all of you for starting this career, and I do hope we get to see you in our circle of women's healthcare.
So I didn't know what a midwife was until I was a junior nursing. I was between junior and senior year I never heard of midwifery. And I was working for a nursing externship. I knew I did want to become a NICU nurse. I was like, that's what I want to do. And I actually did my capstone in the NICU. But it wasn't until I was doing this externship on a high-risk pregnancy floor, and a woman came in on a stretcher, and she was screaming. And a Black woman jumped in and delivered her baby right in the hallway. And of course, I froze. I didn't know what to do. I just watched. But it was how she was with her, how she calmed her. And then once the baby was out, it was like her screaming stopped immediately, and she saw the baby, and she was so happy. And I was like, I don't know what that is, but that's what I want to do. And I was like, what is that? And they were like, oh, she's a nurse midwife. And I was like, a midwife. I want to be a midwife. So I ran home and I told my parents, I was like, I want to be a midwife. I said, I just found out about midwifery. And my dad was like, how do you think where we came from? They were all born in the home by a midwife. And I didn't know that history. And I realized through my nursing education, I never heard of our history and about birth. So I educated myself. And I found out, again, my mother, there was 13 of them. And the last one was born in the hospital. And my mother jokes to this day that she has challenges because of her temper, because she was born in the hospital. So my mother has that joke. But for me, it was like it opened up a whole new world for me. But my first 2 years, because I had to get experience before I applied to midwifery school, now you can go directly into a midwifery program, whether you have a nursing background or not. You can go right into it. So, but I worked 2 years in med surg, even though I just kept saying, I want to do it. And then I worked in an outpatient women's health unit. And I have to tell you, even in med surg, you start to see the disparities in how people are treated. I didn't know how to name it at the time, but I really saw how some people were listened to and some people were not. And then when I went to outpatient, I really saw it, especially with adolescents or just women in general. If somebody was a single mom, they were treated differently. And I said, when I come back, this is where I'm going to practice, and I'm not practicing that way. And midwifery really showed me how to show up for my patients. And I just have to share, like with health disparities, I didn't even know that was a thing, not within my patient population. And I've had patients who we would say are dirt poor. My mother from the South, she always used that term, dirt poor. But they came to every single appointment. And one thing, someone asked me, again, because I had only, I'm going to be celebrating 30 years this year as a nurse midwife. But I only experienced one maternal death. And it wasn't a patient it was a doctor's patient. I did them a favor to do an exam and really connected with her. But the next day she was scheduled for cesarean and had a complication related to anesthesia. And that was my first time. And again, I still didn't understand until I started to do my own research. And my research started in the Black community. And I'll talk more about that. But I really, someone asked me, you only had that one experience, but you didn't see that in your patient. But I realized I learned who my patients were. Mm-hmm. And I'll share this one story. I had a young lady who called and said her feet were swollen. And I asked her other questions, no headaches, no blurred vision. But I'm like, she's concerned about her feet. Let me have her come in and evaluate her. She has severe preeclampsia. She was 33 weeks. Are you guys all learning clonus? I have never seen a patient with clonus until I had that patient. And I knew how sick she was. And again, she didn't have the classic symptoms except for swollen feet. And she ended up delivering. She did okay and the baby did okay. But a little part of me wondered, what if I said, just come in your appointment, just put your feet up. That's normal during pregnancy. But because she expressed it as a concern, I was like, it doesn't hurt just to do a quick exam on her. Mm-hmm. So anyways, I just have to say midwifery, for me, I just feel like I made the best choice in my life. And I'm looking back and I wouldn't do it any other way.
Well, I'm very humbled. I went into midwifery because I felt home. I did my nursing in London back in the time when if you were Irish, it was not a good thing. There was the Mountbatten murder. So I was the only Irish one in my class. So I kept very quiet. But when I did my midwifery rotation as a general nurse, it was at Central Middlesex. And those of you who don't know London, Central Middlesex is northwest London. It's Harlesden, Willesden, big West Indian population and big Irish population. So totally almost 90% immigrants. Most of the midwives were West Indian and Irish. I felt at home. I felt listened to as a student nurse. They would bring you in, they would get you involved, and there's nothing, I mean, even to this day, there's nothing being at a birth that's beautiful. You have to thank the parents because it's something that if I want to make myself feel good, I go work in labor and delivery. Yeah. And that was started so from that as a student nurse, I ended up doing my midwifery. And when I came to the States, they were going to make me do everything again. They made me so PACE, RN to BS, I still had to do everything over again. But I wasn't going to do my midwifery over again, which is why I focused as a perinatal nurse practitioner working with high risk. And up on 168th, the Columbia Presbyterian, where you really could make a difference with your clients. That's it.
Thank you so much for those amazing stories and what inspire you to become a midwife as well as storytelling. Thank you so much. And this is for any panelists. Can you speak more about the history of midwifery in the United States as well as how it has evolved over time?
And this is I'm going to make a long kind of story short. And a lot of my research does look at history of midwifery, but my focus is on Black midwifery. And African midwives came to the United States against their will. They were enslaved here, but they provided care during that journey. They not only took care of birth, they took care of everyone. And I call these midwives, I call them primary care providers because they knew how to care for the community. But I just want you to think about the conditions that they were brought here to the United States and then providing care to women during slavery. Can you imagine someone giving birth in bondage and not knowing what's going to happen to that baby? But these midwives knew, again, because when they were from the community, so they knew the context of the times, but they also knew how to empower women during birth. So they felt empowered in that moment. The woman felt empowered during that moment. And there was safe passage during that time. And then as we start to move, again, we're looking at antebellum, we're looking at emancipation, and where, Black people were considered free. I'm still fighting for my freedom. So just to let you know, we're not there yet. It's still a journey. But at that time, Black women were property, our babies were valued, so we were kept safe. It was safer for us to have a baby during slavery than it is now. I just want you to keep that in mind. But pre-civil rights of the 1960s, keep in mind that, again, nobody wanted to care for Black people. We had separate but equal. And that is not, when I was in school, we were told it was just in the South. That was throughout the United States. It's just the South legalized it. So we couldn't go to the local hospital. There were certain hospitals that cared for people. At that time, they used the term colored. But, and again, they had laws to back that up. So if I came in critical, I may not have been seen. And most cases, we were not seen. And we were left, whatever happened to us because we weren't looked at as being human. But midwives still provided care in their communities, care for Black women, regardless of the conditions that they lived in. I spoke to some traditional midwives. I did interview them for my thesis at Yale, but I also talked to those who are descendants of those midwives. And they talk about how they care for the community, and there was a science to the care they provided. So if you read literature that says they were superstitious, they were ignorant, all of that were lies. I'm just letting you know, but that's a history that you have to look at. But one thing that's important to know is that they used what they had to provide the best care possible. And one of the midwives I interviewed talked about going to these rural areas that didn't have electricity, that didn't have running water, and they still provided safe care to these moms. So they were doing fine in their communities. But what started to change was the ability to make money off of the Black bodies. And that was to learn from the bodies, doing experimentations, practicing how to do a cesarean section. Even going back to slavery, this has been happening. But at this time now, you could make money. And so that's when the shift changed, that people who didn't even want to touch anyone of color was now in their communities trying to provide care. But for them to capitalize off of that, and this is not history I'm making up, this is in our nursing journals, American Journal of Nursing, you can even look up how there was a transition. So what happened, I'm making a long story short, but what happened is that for them to practice and flourish, they had to get rid of the traditional midwives because people trusted them. And there were women who even knew there was a doctor available, but they were like, I'm going to see my midwife. And just to even give an example of the science and what midwives did, there was more than just birth. They provided, again, care. They took care of everyone, men, anyone in the community they took care of. And when a woman was giving birth, the midwife gathered the community. So they had a man that would come, and I'm just using, this is Miss Sarah Penning, her great grandniece, I think is what she would be called. So she was telling me how she would watch her aunt, and everyone called her Miss Penning. They called her mother, her grandmother, by her first name, but they called her Aunt Miss Penning because midwives were very valued in the community by everyone. But there was a shift, and I'm going to get to that shift, but I just want to give you an example of the care they provided. So she talked about how her brother was born prematurely. And during that time, they had people who would come and take care of the kids. She said they would have men bring firewood. They would have people make sure the mother just rested and labored, and they didn't touch. Keep in mind, they knew birth was a natural process. But when her brother was born prematurely, she said, my aunt knew what to do. She warmed brick stones, and she wrapped her brother up and kept him warm. But she also limited people who touched him to cut down on infection. So they knew how to provide this care because her brother would not have made it to the hospital 40 miles away. But just to show you what was in the community. But then the medical community came in, and obstetrics was not even developed at this time. So can you imagine someone coming in that doesn't even know what they're doing, and they say they're the authority. And they said, oh, they're practicing superstitions. They're making Black women harm, or they're causing maternal deaths. And still, I'm looking at the 1940s, 1950s. It was, again, safer to have a baby then than it is now. Because I want you to keep that context, because I want you to show how important it is for us to look at and understand the communities that we work in. But anyways, they had excellent survival rates. But the doctors came in and said, no, we provide better care. They don't wash their hands. They're doing harm. They weren't looking at the poverty that people were forced to live in. They weren't looking at segregation or lack of economic opportunity. They weren't looking at those pieces. They blamed it on the midwives. So if you're listening to that, you still believe it. Because even today, when you hear midwife, how many of you are automatically saying, oh, she gives birth in the home? Or you say, is that safe? It was safe and still is safe to this day. It's safer, again, people are like, oh, I'm worried about the home. But what about the hospital? Are you worried about what's happening where the maternal deaths happen? Are you worried about the hospital? But anyways, just to really get quick, I'm going to make a long story short, sorry. Because it's just, I can't skip through it because there's certain parts that wouldn't make sense. Mm-hmm. So even during this time, medical doctors knew that the midwives had better health outcomes. And these were immigrant midwives and Black traditional midwives. You hear the word granny, but really they were just called midwives. That was a name that was thrown on them. But these midwives provided safe care that I wish I was able to show you a PowerPoint, that their rates were less than half of what the doctors were. And the doctors knew this, but they knew when you look at structural barriers, they knew they had the medical ear. They knew that they could tell women, oh, if you have the baby in the hospital, you're going to be safer. And people bought that. Not to say you can't have a safe birth in the hospital, you just need the right team around you to be able to do that. But anyways, we started to see where, I'll use the South, where 80% of the births were done by traditional Black midwives. But as they started this campaign to eliminate midwives, it was down to like 1%. And that was because people were transferring to the hospital. So you could come, but your midwife couldn't come. We all even know how your husband couldn't even come when births were first in the hospital. So you're taking away what gives people strength and support. So we start to see that elimination that continues to today. Midwifery has been kind of rebirthed, as they say, but the foundation came from traditional Black midwives. And just being a midwife doesn't mean you're going to provide safe care. Because if you don't know your community, if you bring your implicit bias, if you bring all those things with you, because we don't talk about that piece of history, but that is what's contributing to the issues today. But I just want to say that we definitely have a comeback, but we're still doing, I want to say like midwives altogether doing like 8% of the births in this country. So you see the numbers are very low, from 80% to barely 8%. So we're really trying to diversify the midwifery work first, but also increase it. But that was a really quick overview of it.
Thank you so much for that beautiful, you're perfect for that beautiful history. I just wanted to add maybe two things to what was just shared. So when we go back and think about these traditional African midwives who were enslaved, they knew that wherever they were going, they had to be the person that continued to provide that care. So one of the things that they did before they were boarded onto these slave ships was to put seeds into their hair to make sure that when they got to wherever they were going, they could plant those seeds and have the foods and the herbs that they knew were going to support their communities, their families, these mothers, these babies to survive. And it was crucial that they survived, not only for the midwives, but also for the slaveholders, right? Because we were a commodity as Black women. If I was bought for $300, but then I gave birth to 10 children, that was essentially 11 for the price of one, right? So there was a profit in it for us. As soon as slavery was quote unquote abolished and there was no longer a profit, it was how do we stop them from procreating? So as was just shared, where the hospitals were segregated and we couldn't get care, another thing was happening. Those granny midwives that we've now exalted to grand midwives, right, in the South, they were told that if you provide care for your communities, we will put you in jail. So that meant you were telling a pregnant Black woman, we're not going to accept you in this hospital, but you also can't get care in your community. Pregnancies didn't stop, right? So where were you going to get care? That was almost a death sentence. But we had these grand midwives who still went against the grain. They risked their freedom to continue to provide care. They fought to get admitted into these nurse midwifery programs. And we are seeing a resurgence. And I think it's really important that we understand that, as was beautifully illustrated, our great-grandmothers were doing better in terms of birth outcomes than what's happening present day. So there has to be a collaboration of all different types of healthcare providers. There have to be midwives in hospital. There have to be midwives who are also doing collaborative care for higher risk populations. But we also have to understand that when we're talking about these disparities, and this is really important, as much as we hear Black women die 3 to 4 times more, 8 to 12 times more, it's not that there's anything inherently wrong with us. It's the way in which Black and Brown is treated in this healthcare system, right? So when we understand that, we have a due diligence with the providers to make sure that they are not inflicting this implicit bias. And that's going to be a challenge because a lot of the education is steeped in harm, right? We have J. Marion Sims. I'm sure you probably have heard that name in your education. He's known as the father of modern gynecology, who did numerous obstetrical surgeries on enslaved Black women without anesthesia to prove his theory that they don't feel pain in the same way that they can endure it, right? So just because they endured it didn't mean that they weren't suffering, but that model was used not to humanize them, but to have that ability to send them right back to their enslaver so they could procreate and have more children, right? So when we have these frank conversations where we talk really thoroughly about the history, we have the opportunity to not repeat those negative, things that have happened, and to also honor, those midwives who fought so hard for us to provide the type of care that I know you all are going to be providing.
Yes.
Thank you so much for that history. And some of the things that you mentioned, I've always thought about, my late grandmothers who had anywhere from 6 to 10 kids, maybe even more, over the span of over 20 years. They were having kids into their 40s and they lived to their 90s. Okay. Mm-hmm. And now we have women who are their first child passing away. Mm-hmm. And also thinking about how one of the things they mentioned is the midwives doing delivering babies and taking care of communities without all of this equipment that we have today, without all the technology. So not having C-sections, right? So a lot of our postpartum deaths, they do occur after C-sections. That's something that I sent that out for the nursing students to review with our state surveillance report. But over medicalization of birthing is what we've become accustomed to. And just in general, of having, rushing to surgery, rushing to take medications when maybe not appropriate or not necessary. That's the social conditioning. So ideally, we would want to go back to community birthing. I just want to also transition over to Dr. Burke. So the U.S. has significantly higher maternal mortality rates in comparison to comparable developed nations. Recent statistics show that the U.S. versus U.K. mortality rates are 32.9 versus 13.41 deaths per 100,000 live births, respectively. Discuss some of the differences you observe in the models of maternity care in the United States versus the UK, as well as your experiences as working as a midwife in the UK.
All right, so there's one of the biggest difference is the number of midwives per 1,000 live births. So that's first off. The UK's got 48. All right, the average is 49 in other countries. I think Sweden and Australia have got the highest. They're up in the 60s. Anyone like to say how many midwives per 1,000 live births we have in the United States?
Take a guess. Sarah.
4.
Okay.
Yeah. See?
Wow. She did her reading.
Wait. That's amazing, isn't it?
Yeah.
So when you were talking about 12,000, Dr. Barnes was talking about 12,000 births are actually attended in the US by midwives. When you look in the UK, it's over 50,000. Now, when you look in Ireland, it's 90,000. All right. 90,000, 90%, sorry. Oh, we're talking percentages. 12% in the US,
12%.
yeah, 53% in the UK, and 90% in Ireland. When we look at the models of care, Ireland actually has a obstetrically governed model, even though there are more midwives and there are more midwife deliveries. But that goes to talk about balance of power. So they might think they have the model of care that's directed by obstetricians, but actually they're getting more midwives with their deliveries. In the UK, it's a midwife-led model of care. However, they have identified, even though they're doing better than us with their outcomes, there's still a gap. There's a 4-to-1 gap between black and white maternal mortality in the United Kingdom. Now, you can't say it's to do with insurance, right? Because guess what? What does the UK have? National health insurance, right? So take that out of the water there. So what do you think it is? Implicit bias. And now the move is having women-led care, where we're actually listening to what women are saying and what their experiences were and how we can make that difference. All right. So that's just like a little bit of background. It's better, but it's still not good enough. It still has to improve. All right. And then if you look at the differences in care, the clients are allowed to either have a community home birth by a community midwife, or they can have a community delivery in the hospital. So if you have somebody who's had a high risk, like let's say somebody had a forceps, an assisted delivery, they are not cleared for a home birth. So they would be delivered in the hospital, but with a midwife delivery and have everything on standby as needed. And then there's the hospital births where all of the births for the majority are by midwives. Everybody who rotates through the midwifery services, you have anybody who's a general practitioner, so that would be your primary care. They have to rotate through OB services. Any health visitor or any district nurse. District nurse is like your visiting nurse. All district nurses have to rotate through OB. Why? Because when you're out in the community, who said that everywhere you meet a pregnant person, right? That was you. Dr. Canty, yes. Right. So they have to be able to cope with, basic screening of pregnant patients. So even if they have an earache, guess what? We're checking them out, right? And so those are some of the big differences. I think the other part of that is maternity leave. We don't give maternity leave here in the United States. I was in shock.
Yeah.
You know, if you take time off, you've got preterm labor and you take time off before birth, you have less time off afterwards to spend with the baby, right? So maternity leave is a big part of that. Education, 24/7. We had a hotline 24/7. Each maternity hospital had a hotline. Do we have that here?
No.
Some people provide it.
Barely.
Some people provide it, right? Some people provide it.
Yeah.
But how cheap would that be to provide 24/7 with algorithms as a hotline for patients who are pregnant and the first year postpartum, right? And I think that was so those were like some of those. The focus is more on natural birth. And when you're talking about midwifery-led programs, all of the residents, their house physicians, they used to call them, so they would have to do their OB rotation. They got a letter saying that it was the midwife who managed the care. Not the doctor, not them, because they were a resident and they had zero, almost, experience, but it was the midwife who led the care.
Yes, and I just want to say something really quickly about that, why there's a difference in the United States. When they did come in to take over traditional midwifery, they introduced nursing, and there was no evidence that being a nurse meant there were better outcomes. But OBs could control the nurses. Very early OB nursing, and I'm saying OB nursing texts were written by obstetricians. They had a medical model. So sometimes that still shows up today. With nursing, we have a different way of our relationships with our patients, but the roots really came from obstetricians. So we're opposite. I would love to have had someone come in and say, she's in charge.
They actually got that letter.
We could restart that.
Yes, we should. We should. Yeah.
Thank you so much for sharing the different models of care also, because the majority of births are considered low risk. So women can have options to give birth at home, give birth in the birth center, or anywhere in the car, doesn't matter. Okay? So I want to switch over to Dr. Mayer. So during your career, you started and led the Northwell midwifery practice at Huntington on Long Island. Discuss some of your past quality improvement initiatives done to improve outcomes in any perinatal community partnerships.
Okay, so how much time do we have? So I will admit, at the time, the practice started in 2013. I was approached by the director of OB at Huntington Hospital because he could not understand why women were leaving the Huntington area and going to Stony Brook Hospital to have their babies. And the answer was they were seeking out midwifery care. So as he was a wonderful chairman, and he was now looking for a midwife presence at Huntington. And my resume, my CV, actually came upon his desk and he called me. So we had a conversation, would I be interested? We were doing it a little under the radar. He wanted to see how it worked out. The deal was I was given a year. If the practice was successful, then we were going to move forward. But for the first year, I would be the only midwife. And as Camilla had said, I certainly started in a hospital office. I mean, cost was a big factor. I started in a hospital office. I was allowed to see patients 2 days a week, but I had no patients. So I certainly I was the only midwife there, so I had no other midwife to model, care after. So what I did was I sought out the organizations in the community that could help me. The first organization was the Long Island Doula Association. So obviously we have a lot of Brooklyn and Bronx and all city-bred midwives here, but I was strictly Long Island, so that was my community. And truly, I'm sorry to say that the culture here was not to embrace midwifery. The model of care was you go to a doctor and you do what the doctor says, and if he wants to induce you at 39 weeks, then that's the plan. So as a midwife, we certainly wanted to change that. And I realized coming to a community hospital where there were a lot of, and you'll know when you look for a position in labor and delivery, they're very rare because the old timers never want to leave. They want to stay there forever. So the issue was I could not go in. I did try. I mean, I certainly did many presentations about midwifery, but they had a very bad taste in their mouth from the prior midwives in the community that had gone in to deliver their babies. So I realized that you need the support of nurses. You're always a nurse, in your heart. And so I needed the support of the nurses, and I needed to show them what I could do as opposed to just telling them what I was going to do. So without any patients, patients, it wasn't very easy. The practice did grow. I eventually delivered 20 midwife patients that year. But what I did was, Huntington Hospital was unique. They had a community that included a place called the Dolan Family Health Center. And that was a community-based clinic-type setting, but the majority of the patients were Hispanic. They would come. These are our, the immigrants who came over who had no care and needed, to have prenatal care. So they all registered at Dolan and they delivered at the Dolan Family Health Center. So I found an opportunity, while I was building up the practice, to offer my services. Let me help. I can help deliver, these women. I can help deliver women who come in without care if I'm here. And that's what happened. I started to deliver many babies, and over the course of the year, the nurses could see what midwifery care was. I tried to get away from the idea that you needed many interventions. You could be very patient in the care, let nature take its course, and that's how we proceeded. I hardly ever cut an episiotomy. I mean, that was just something that we knew how to do, but we certainly didn't use it. I certainly didn't induce patients. We induced for medical reasons, or, because, and that was it, for medical reasons, or never, I didn't play golf, so I didn't have to worry about that. And I shouldn't really say that. I know that's a very bad association. And I don't want you to think that as a midwife that I do not get along with physicians. I will be very honest. I worked with a physician for 19 years. It was a wonderful collaboration. And the doctors that I met in Huntington, they were thrilled to have me there. They were thrilled that we were working together. I appreciated their help and their input, because even midwife patients have problems. The first patient I delivered she presented with a very bad picture, and she needed a C-section. And I said, I couldn't believe it, the first patient. But as midwives, as a midwife, I wanted to be part of the continuity of care, whether a patient had a C-section or not. So I became a first assistant for C-section. And I know it sounds very opposite. We're trying not to be, and trying not to utilize a lot of medical interventions. But I found that the patients loved the fact that I stayed with them. I stayed with them in the C-section room. I helped deliver their babies. So it became an asset, and the patients felt very comfortable. But I just needed to comment now. In our practice, what I did in the beginning was we would have something called a meet and greet, because, many people were very resistant. As it was said already, you're a midwife, you deliver at home. No, do you deliver, you bite the bullet? No. And so the patients would come in, women would come in with their husbands, and I would say, so who in your family isn't sure about you having a midwife attend your birth? Well, my mother, my aunt. So I said, well, bring them for the next visit. We wanted to educate the community as to what we could provide for them. And one of the key things that we did was we opened the communication lines. You have to listen. What midwife is being with women, and you need to listen to what's important to them. And I could, go on, the stories I heard. I heard you speak at the library. So I told you LIDA, Long Island Dual Association was the first place. I went everywhere. I went to schools. I went to libraries. I was looking for anybody that I could speak to about midwifery. I spoke to the nurses in the hospital. And I will tell you, I think the proof is there. Many of the patients we have are nurses from the hospital, because they have seen what we have done. So I would hear stories. My doctor wants to schedule me an induction. He doesn't even want to hear about my birth plan. So of course, these are the important factors that women want to come to. That they're smart. They know what they want, and they wanted someone to listen to them. Even if we had a patient who already had a C-section and was going to try for a vaginal birth, we had great success with our patients, and that's another reason that we acquired a lot of patients, because we were open and many of the things they would say is, I just want a chance. I just want somebody to say, can you give me a chance? And that's one of the things we did. So the meet and greet was it was well received. We wanted to be very clear. We can't promise you a vaginal birth, but we will promise you a healthy baby, and we will promise you that a midwife will be with you. And that was one of the driving points that I wanted: 24-hour, 24/7 midwifery availability. I didn't want the patient going to the hospital and having the doctor deliver her. We wanted the patients to call us. So we had an answering service, and our patients could call us 24/7, and that was one of the big differences that we made for the community. As I said, we worked with other physicians, and I will tell you, in the office I shared with breast specialists, and it was a women's health center where my office was, and I did share the office with maternal fetal medicine, the docs who evaluate the sonograms, look at the sonograms, take care of higher risk women. And I will tell you, we established such a wonderful relationship with them. They loved working with us because they knew that we cared about the patient, we knew the patient, and when we came to them, and they were available to us as well, 24/7, I could call them anytime. When we had a patient and there was a concern that we had, they helped us immediately. So we offered a lot to our patients, and I believe that we made a difference. During the course of the 10 years that I was there, we also collaborated. There was a Planned Parenthood office in Huntington. The nurse practitioners there were able to provide prenatal care, but they could not deliver at the hospital. So we made arrangements with them to have our patients from Planned Parenthood come and meet us so that we could provide them with care as well. So we found many avenues that we could, again, say, listen, this is our midwifery model of care, and we review it. We try to use as little intervention, although we do have our patients looking for their epidurals, and, patients call me from the car, I'm ready for the epidural, please, please. But we have patients who say, I don't want an epidural. I want to have this, baby without medication, and they're happy to know that we support them and that we have many, many interventions that we can use. I mean, in the hospital, we use, we don't have to deliver in lithotomy. You can certainly deliver in any position that you want. So we try to create a very home-like birth situation, knowing that if there was a problem, we had 24/7 anesthesia, we had 24/7 neonatology, we had 24/7 physician if need be, and that helped a lot of patients make their decision about having us provide care. And then the more that we delivered, and they could see that no, they don't really induce, no, they don't cut episiotomies, no, they certainly give you, they give you much time, for your labor. You can take showers, you can walk around, you can ambulate. We used many different techniques. And that was really only part of the experience. That was really during their labor, but during their antepartum care, we listened to what they said. I was very lucky to be able to have a lot of time to spend with our patients so that we could really go over situations that they have, so we could make sure that they're doing okay and have any concerns. And we followed through then and through labor and delivery, and then we would round on our patients for their postpartum visit. So we were there to see them. We were the ones who sent them home with instructions, and we were the ones that communicated with them if you have a problem. The swollen feet, you get those calls, and when you're getting the call from your patient who you know she's calling you because she has a problem. And so I think that makes a big difference in the care that we give, and knowing that our patients have issues. What are the common reasons why women will die? I mean, it's because of hemorrhage, it's because of the preeclampsia complications, it's because of stroke, cardiovascular issues. And they did back in 2013. They started Safe Mother Initiative here in our hospitals. And so we as midwives, we also, and I'm always was joking, these are the things that we always did, and now somebody is validating the things that we did. And especially, for the women who are high risk, they still want to have their baby too in a certain way if they can. And so skin to skin, midwives have been doing skin to skin since day one, yet now skin to skin becomes something that, oh no, everybody needs to do it. It's just so funny. The same with breastfeeding, the same with the skin to skin, and the same with, doing less intervention. So as I said, I certainly could go on, but we do follow through also with our patients. We bring them back for early postpartum visits. We don't wait 6 weeks or 8 weeks to see them. We bring them back based on what we feel their need is. We'll bring back new moms in a week to 2 weeks, especially if they've had an issue, then we're certainly going to see them. We follow up again, and then we set them up for their annual visit in 3 months so that we have close contact with them for the next, for the time after they have the baby. And we certainly open the communication line so that they feel very comfortable calling us.
Thank you so much. And that was such... I mean, if you were listening to how comprehensive these practices are in Huntington, thank you so much for leading the way. You're certainly a trailblazer for Long Island for midwifery care. Absolutely.
More midwives. Come on. Go
absolutely. So we need more midwives. And also, I also want to comment on what you mentioned about golfing, because it's a real thing. It's a real thing of having, so one of the midwives that was mentioned during Nubia's bio was Jenny Joseph, who is a midwife who was trained in the UK as well. And she posted, this was a couple months ago, on her Instagram, as Common Sense Birthing. And she had a series of posts of why, basically, that birthing should not be rushed and how that can lead to adverse outcomes. So, talking about, C-sections, or also around the holidays, there's increase in cesarean sections, planned scheduled deliveries, right? We know Kira Johnson, who passed away at Cedars-Sinai years ago, who had a planned C-section. It was not medically indicated. So C-sections can save lives if there's an emergency, but when not medically indicated, it can cause risk, just like any surgery. It's blood clots, postpartum hemorrhage, accidentally nicked an artery or things like that can happen, or sepsis, which is infection, or other complications. So she had this post about not rushing the birthing process and what to do if a patient feels like they're rushed. Also just the mindset of, okay, it's around the holidays, but that doesn't mean that, or if you're at a certain week, I've heard even one of my nurse practitioner students was telling me that she was being rushed to deliver at 37 weeks via C-section. She did not have any complications. And the weird thing is that I told her, I said, oh, by the way, don't give birth on your back and don't let them do a C-section. And everything I said is exactly what they did. And she came back to class, and she still hasn't healed from her C-section. Partly because she's also, when we talked about lack of medical leave, she's working 12-hour shifts. She's taking care of the baby and her other kids and her husband, and also just running around and trying to graduate from this program. But that's not maternity leave. Also, there's paternity leave. One of my sister's friends they all live in Spain. The fathers have paternity leave as well to bond. So in the U.S. we're so we're so socially conditioned to feel like, oh, if you're not working hard enough, if you're not working up until you drop, then you're lazy. There's times that your body needs to heal. You need to rest. You need to recover. You need to set boundaries. You need to turn off that phone, or disconnect from the phone. We really have to be mindful of all those things that are causing stress during pregnancy as well and causing adverse outcomes. But the most important thing that she said is that midwives are not in a rush for the baby come. The baby comes when it's ready, unless there's a medical emergency. Mm-hmm. So thank you for pointing that out. We do have to wrap up. It went by so fast, but I just want to quickly go down the line in a hot, I don't even say a New York minute, but New York 30 seconds. Last remarks, maybe something about your organization that you're doing, or general remarks about maternal health care in the United States. Go ahead, Dr. Burke.
Okay, I'll just start about technology and interventions. So we know that we're hot on technology, but there's a term that's called the cascade of interventions, which means that the more you intervene, the more you have to intervene. And when we talk about fetal monitoring, and we can ask the midwives afterwards, that do you use continuous fetal monitoring, or do you intermittent? All right, because all of the studies that showed fetal monitoring came in the United States in the 1960s, and it was supposed to help reduce neonatal outcomes or improve neonatal outcomes. And all it did was increase C-sections, which increases maternal mortality, right? And it increased neonatal mortality and morbidity. So that's my tuppence about technology.
Okay, so I just want to mention briefly, first, a monitor. If you're in labor and delivery, I don't know how many patients said, everybody looks at the monitor. And I want to be like, I'm here. I'm right here. I'm the one giving birth. Yeah. But so just as far as nursing care, when we say prevention, we say that I don't know the statistics for New York, in Mass and Connecticut, 90% of the births, of the maternal mortality deaths are preventable. That means if one thing was done, that death could have been prevented. Mm. As nurses, you're at the core with any patient. So it's so important, again, to learn your patient. But when we see a patient crash, there's always signs within 24 hours. So a patient just never goes from 100 to a 0 in 5 minutes. There's usually some simple symptom, whether it's her rate, her blood pressure, her pulse rate, her respiration. There's always something. So please, I always go back to, you want to improve care, go back to doing a history where you listen to the mom, and go back to doing a physical. Put your hands on a patient. I can't tell you how many patients were evaluated without nobody touching them. And then now they're wondering why they're in the ICU. So anyways, I'm just saying, as nurses, stay tuned to your patient from their mental well-being, that when you start to see little changes. And the most important thing, again, is listening. First, trust birth. Our bodies know what to do. Complications will happen. But if you know those warning signs, again, you could prevent things from going too far.
Yeah, I'll just.
So sorry to interrupt you guys. This could go on for forever. We absolutely love it. There is another program after you.
Oh my goodness.
So just on behalf of the inaugural class and all of the faculty here at Hofstra Northwell School of Nursing and Physician Assistant Studies, I thank you personally, and I believe that the class has something to give you all.
Have some gifts, and thank you so much for your time.
Oh my God.
Thank you so much.
Wow, we have to come back.
Thank you.
And thank you so much for your time for this event.
Beautiful.
Dr. Smith.
Thank you. Oh my God, first I thought you were all leaving.
Dr. Links.
If I can just add, watch Aftershock on Hulu if you haven't
yes.
yet. That was the only thing I was going to add.
And I will just finish up by telling you, it has been an honor for me to be a midwife in my career. Midwifery has certainly made a difference to my life and the lives of the women that I've taken care of, not only through birth, but throughout their whole life. So I believe that if communication to me is the key in all aspects, with your team members, with your partners, with your patients, and with their families. So, and I wish you all good luck. I'm so happy that we have an undergraduate program now. That's awesome. And you guys are going to be the trailblazers. Congratulations.
Great.